We are live.
So welcome to this AIOSS Scientific Committee webinar today, and we present Ophthalmology Pathshala in coordination with the Micro Knowledge Academy, which is by Microvision. And I think today we are going to talk on a very important topic, topics which are not given in the books, topics which come out of experience, and topics which do require a lot of attention, which we actually only come to know about as we experience during our practices, whether it is institutional or it is private practice. So we are going to be talking today about the PROM, that is the patient-reported outcome measures, and the PREM, that is the patient-reported experience measures in ophthalmology. I have a galaxy of speakers with me, people who are renowned in this field for several years. And we would begin our talks now. We have three speakers, followed by the panel discussion, which will follow. And it is my pleasure to introduce the first speaker, Dr. Dr. Lalu Joseph. Dr. Lalu Joseph is going to be talking to you about overview of importance of PREM. She's associated with the consortium of the Accredited Hospitals Organization and is the Secretary General. I was told just now that they are into 27 countries, and they have trained close to 70,000 people who are associated with the quality care. And we are going to listen to her first talk now. So over to you, Dr. Lalu Joseph.
Thank you so much. Very good evening to everyone. Thank you, AIOSS, for giving this wonderful opportunity. I bring greetings from the Christian Medical College, Vellore, where I serve as the Patient Safety and Quality Manager, and also from the Consortium of Accredited Healthcare Organizations in India. We are established to promote quality, patient safety, and accreditation in the country. So I'm going to be speaking about patient engagement tools with special reference to PREMs. This is a newer thing in our country. And exactly what is it? How is it different from other tools that we are talking about is what I'm going to be spending the next 10 minutes on. All of us know this is not something new to us, healthcare and safety. The odds of dying in a plane crash is very, very minuscule. Though we get very, very scared when we get into the flight, a small turbulence, and I think we get scared that the flight is going to go down. Fortunately, that's one of the safest industries, but we really can't say this after the Ahmedabad accident. Yet things like this happen, but whatever said and done, due to medical error, the odds of dying, it is proven it is 1 in 300. So it's extremely hazardous for a patient to be admitted in a hospital because data states from WHO that it is 1 in 10 patients who receive harm in developed countries while receiving care. In developed countries, if it is 1 in 10, then we can imagine the quantum of errors, the mistakes that we make in developing and underdeveloped countries. We don't have data tracked on the number of errors, the near misses, except in some accredited hospitals, we do it because accreditation exercise warrants that we capture. Slowly, the culture is changing, but yet we do not have a proper reporting system. So therefore, healthcare is now compared to under the most hazardous industry category, which is equivalent to bungee jumping. You are safer when you climb on top of a cliff, tie yourself to a rope and jump from the cliff rather than getting yourself admitted as a patient in a hospital. So that's the analogy that is drawn. And we are aware of this pretty lady. And many people say that she underwent, when I put up this picture, that she underwent 27 plastic surgeries. But little do we know that her mother, Rajeshwari Ayyappan, was operated in Sloan Kettering, the leading center for neurosurgery procedures in the globe. And she was operated in 1996 on the wrong side of the brain. If this could happen in a leading center, I'm sure it can happen anywhere. And all of us would have witnessed at least 1 or 2 errors during our time, even if it is 2 or 3 years in a hospital setting. The culture in our country or any underdeveloped country is like this. We see this day in and out. This morning, I saw 3 elderly ladies going on triples right in the middle of Vellore without any helmet and had a fall right in front of my eyes. So this is not new to us at all. And this is the culture. our healthcare workers also come from similar background. They come into our hospitals without helmet, and then we expect them to take care of the patients in a very safe manner when they enter into the portals of our hospital. So that's the irony. So culture starts everywhere. It has to start from the schools, but unfortunately, we do not have that. But how do we really maintain this workforce? Everybody talking about safety is a huge burden on healthcare organizations. Failures in healthcare delivery are not new to us. We see this every day. Medication errors, wrong patients operated, wrong site surgeries, wrong medication, retained objects. Look at all this, the number of incidents that we listen to on a day-to-day basis, whether it is fire in hospital setting or people losing their lives as a result of power cut in hospitals or wrong medications, getting, young people getting operated on wrong leg and lots and lots. Now, this is the data from a developed country, NHS data. Despite several measures in place, we still continue to have in developed countries never events, which are events that should never happen. For example, a wrong patient being operated or something lethal happening to the patients in the hospital. So with all the accreditation exercises, the protocols, policies, stringent measures in place, we do have these errors reported in even developed countries. So if you go into the split up of this data, you realize wrong site surgery in NHS in 1 year was 179 cases. Retained foreign objects 81, wrong implant prosthesis 37, wrong root medicine 20 cases. This is in a developed setup. Now, repeating the same mistakes like this, wrong site surgery, retained objects, wrong implants, are we really doing enough? We do have lots and lots of policies, protocols in place. We all have our manuals in place, stringent SOPs. And despite all that, are they being followed is the bigger question. The quality teams, quality managers, clinicians, administrators have SOP manuals. They put down all these policies. Are they really being followed is the question. Processes and pathways, are they robust and clear? Or is it just copied and pasted from other hospitals that we want to just do it for an accreditation exercise? We have several guidelines and checklists. Are they consistently being used? Are they becoming tick lists just for the sake of satisfying some accreditation or assessment exercise? That is the question. So we do realize, despite all these policies, protocols, SOPs, accreditation, we continue to have errors. So we do have a weak link. Now, what is that weak link? How do we really sort this out is the bigger question. And WHO has clearly brought it out that patient can become a partner with you. And when you partner with your patients, then that weak link that you have could be, made sure that it is all right. So earlier we used to talk about patient-centered care, and now it is all about patient-driven care. How do we really engage with this patient who's lying on the bed, probably for 2-3 days with you? How do we engage with them and make sure that they partner with us and have good safety systems alerted to the healthcare workers? So in 2023, WHO had this wonderful theme on the World Patient Safety Day, Elevate the Voice of Patients. They gave global recognition, highlighting the importance of patient engagement, amplifying the voice of patient, and also brought out a very responsible statement, which is shared responsibility. Patient safety is a collaborative effort between the providers and the patients. How do we really do that is the question. There are several tools available. We take feedback from patients. We do have patient portals. We have support groups, patient-reported outcome measures, social media platform, patient educational material, patient advisory councils, and patient-reported experience measures. We at CAHO started focusing on 3 major activities. One is the Patient Advisory Council. How do we give the patient a seat at the table, at the boardroom? How do we listen to them? They become partners with you. They can give you constructive feedback of actually what is happening on the ground and help you deliver the services better. And then your outcomes could improve. The second one is the patient-reported experience measures, which is what I'm going to spend the next few minutes on. And the third one is the patient-reported outcome measures. Now, let me get into patient-reported experience measures. What is it? It is a self-reporting instrument that measures patients' perception of experience while receiving care. Is it the same as patient satisfaction surveys? Certainly no. They are distinct from satisfaction surveys. Currently, they are being used interchangeably with satisfaction surveys, but certainly they are not the same. PREM versus satisfaction survey. Let me give you a distinct example. Items or the questions in a satisfaction survey. For example, if certain type of information was provided to the patient on admission or discharge, rather than whether the patient was satisfied with the information. So in a PREMS tool, you ask them, were you given adequate information about follow-up? That's it. In a satisfaction survey, you ask them, were you satisfied with the information provided to you during discharge? So there is a difference between asking certain questions and also asking them about their experience. What PREMS does is, it seeks to record what actually occurred. Did this particular thing happen at all? That is what PREMS gets into from the patient's perspective, rather than evaluating whether if it happened or not. So there is a difference between evaluating versus whether it happened or not. So PREMS is all about whether a particular thing happened during the care delivery, whereas satisfaction surveys are about evaluating the service that is provided. So there is a difference between these two, and that's what we try to do, which is intensive monitoring in each step of the care episode. I have gone through several eye surgeries, and I was always concerned that I should not be operated on the wrong side, wrong eye. So I would always keep my hand over my right eye to make sure that the surgeon knew that this is the eye to be operated upon. I was an engaged patient and I would never allow my surgeon to make the mistake. So that is the engagement that we are talking about. Now here, if you ask your patients, for example, in a MRI PREM, did the doctor take a consent from you? Before the MRI, were you asked about any implants? Did anybody explain to you what to do in case you feel claustrophobic? Did they check your creatinine level if you had a contrast? So if such questions in a validated format based on the SOP is being asked to the patients at regular intervals, then you know whether there is a slip in the protocol or not. And then you can actually go back and correct your protocols or the compliance to the protocols before a real incident happens. That's all about it when we talk about PREMS. Now, what did we do? So there are several uses that we understood when we looked at the literature, and this concept was introduced to us by Dr. Rahul Deshmukh, an anesthetist from Aster at Dubai. And we realized that we could use it as an excellent tool for engaging with patients, number one, getting their feedback about the protocols and its implementation on the ground. So potential uses of PREMS, useful measure of what actually happens in care episode. It's a very proactive measure to identify areas for improvement if the protocols were not implemented, to assess the effectiveness of the CAPA that we have put on the ground, whether it's actually implemented on the ground, to improve communication because you're talking to them, trying to understand from them what exactly happened with a structured questionnaire, opportunity to elevate their concerns and becoming a voice by co-assessing care. That's the whole idea of this PREMS. So even though the concept of PREMS is not a new one, until recently, it was believed as a tool to assess service excellence. But we believe that this is the first time that PREMs are being used to identify gaps in clinical care as a tool to assess gaps directly from patients in safety measures that could potentially lead to harm. Ask the right questions to the patients, and this idea of validating context-specific PREMs to assess processes that impact patient safety. So we embarked on this beautiful exercise of developing validated context-specific, rather India-specific patient-reported experience measures tool to enhance quality and patient safety. And that's an initiative that we undertook. Both Dr. Nirmal and Dr. Samina have been part of this as PI and co-PI for the cataract and several other PREMs that we actually developed. So the 17 project areas that we worked on with 17 ethics committee approvals from several institutes and with the help of 450 institutes in this country, we have now validated the 17 PREMs that we worked on, starting from MRI to cataract and dialysis and antenatal care, anesthesia. We have actually done this exercise. It's all validated and published as a white paper available free of cost to any hospital that wishes to use them. So now we are in the process of publishing this. Several of these have already been accepted for publication. Now, this is the portal where it is available. You'll have to log into the CAHO website. It is a free download. It is available in 13 languages, all the 17 tools with a single mission: excellence in patient safety. So these tools are available for you. You could download. I will also try and share it in the chat box. The key takeaways: enhancing patient-centered care, co-producing with the patients, and all these 17 tools were co-produced with patients as partners. Standardization of care, so that we bring in standardization of protocols across the country, consistent and high-quality processes. Co-assessment, we engage with the patients and jointly evaluate the outcomes of these SOPs. Ensuring patient safety is the crux and minimizing risk and harm. Thank you so much for giving this opportunity to set the, just an introductory note on PREMs. I'm sure Dr. Samina and Dr. Nirmal will elaborate on both the tools that I talked about. Thank you so much.
Thank you so much, Dr. Lalu Joseph, for giving us that insight. And I think the message was clear that patients are partners with us and we cannot isolate them. We have to work in unison with each other. It is my pleasure to invite the next speaker, Dr. Nirmal Frederick. I think Dr. Nirmal Frederick needs no introduction at all. He's known to all of us so well in ophthalmology circles and also in IMA. He's responsible for spearheading so many quality control programs as far as ophthalmology is concerned. And he's going to be talking to us about patient-reported outcome measures, evaluating patients' perspective about outcome of cataract surgery.
Thank you, Dr. Namrata. Thank you, AIOSS, for the invitation. And I'd like to extend a warm welcome to Dr. Lalu Joseph, who's been here spearheading CAHO and probably one of the best quality institution in our country, CMC Medical College. Welcome, Lalu. Thank you, Samina, for the invite. And good evening, everyone. So today I want to share with you a paradigm shift that's quietly revolutionizing the quality field with reference to ophthalmology and the implementation of patient-reported outcome measures and patient-reported experience measures. So thank you, Dr. Namrata, for asking us to talk about this and sharing our inputs on this. And we all know that we are in the digital age and digital stage. So this hospital really looks beautiful in and out. And I happened to visit this hospital. But what surprised me and intrigued me was presence of so many wheelchairs. The hospital did had a wonderful big lift and ramp, but this floor had only the wheelchairs lined up in front of the rooms. So I asked them why so many wheelchairs. Are these patients have some physical challenge? And later on, the nurse came and told that we cannot bring these stretchers here. Unfortunately, the stretcher turnaround radius is very small here near the entrance. So we have to use only wheelchairs. So mind you, this was a 3-floor structure with wonderful aesthetics. But unfortunately, the architect failed to discuss with the users, and this was the outcome in spite of spending so many crores. So same thing happens in many of our day-to-day life. Let me start a well-designed hospital, but not being properly used. So how many of you have had a patient say, Doctor, my vision is 6S, I still have glare and eye strain, which they cannot explain, say something bothering me and something, and trying all such gimmicks to show that if through a pinhole they're getting a better vision, or through the glass, they are getting better, or if they look down, they are getting better vision that is usable for their day-to-day activities. So cataract surgery outcomes, we all know this crossed about 95 to 98 percentage as per our measures. But in this study, 16 percentage of patients reported reduced vision after surgery. Of course, 83 percentage reported improvement based on 3,050 studies. So the fundamental problem we face is we achieve 98% technical surgical success and patient attains 6/6 vision, but yet 15 to 17% remain unsatisfied. So the critical question emerges, are we measuring what matters to our patients or just what's easy for us to measure? So this is a disconnect, and this disconnect between clinical metrics and patient experience represent a fundamental gap in traditional ophthalmology. So we rely heavily on what we can measure, and so even though we can provide technical success, 15 percentage, or in some cases even 20 to 30% patients are unsatisfied with the vision. So the problem is traditional ophthalmology relies heavily on what we can measure, the visual acuity, IOP readings, the metrics we all do day to day in our clinical practice. And patient with 6/9 vision might function better than someone with 6/6 vision. So somewhere there is a disconnect. So three key gaps exist. The visual acuity doesn't equal visual function in daily life, and perfect intraocular pressure control doesn't guarantee safety of vision or quality of life. And surgical success by our metrics may not mean patient satisfaction. We also need to understand the patient demographic is shifting. So we are now seeing digital generation. Modern cataract patient profile is also shifting towards excessive near work requirement and digital device users and excessive screen users. We are actually treating smartphone users, not just elderly patients. So what are patient-reported outcome measures? So this basically reports from patients about the health status without interpretation by clinicians or researchers. We already told you about the gap in traditional assessment, and this is one approach to reduce that gap or fill the gap. So two important parameters, patient-reported measures and patient-reported experience measures. Dr. Lalu has already explained about this, but PROM is basically a patient perspective on how illness or care impacts their well-being, and patient-reported experience measure is their experience with the entire healthcare system, right from parking to admission process, discharge process, etc. So in the next 15 minutes, I'll try to cover these objectives since the concept is relatively too new to many of us. I'll just focus more on the basics. There are types of patient-reported outcome measures in ophthalmology. It may be generic comparison with the other disease elements. It may be vision specific, or it may be disease specific like cataract, dry eye, glaucoma, or diabetic retinopathy. So there are many tools for PROMs. For cataract, we use the CatQuest 9SF. This is basically a tool used by ICHOM. This is the standard set of recommendation for cataract outcome measurement. It was initially used to understand the benefit from the second eye surgery in the Swedish national study. Later on, NHS adopted this measure to improve the preoperative counseling of patients and the postoperative functional improvement assessment and benchmarking between various surgical centers for payment. And there are other ophthalmic PROMs, particularly the glaucoma questionnaire called as POEM. And so this specific tool measures quality of life and quality of vision for glaucoma patients under treatment. And we all know this, and this is many of us are following the OSDI index for dry eye disease, not only for grading, but also understanding the patient complaints and trying to manage the dry eye for them. So why PROMs matter in ophthalmology? Because of the gap in traditional assessment And now there are regulatory requirements for drug approval. Recently witnessed an issue with a drug which was promoted heavily, but the regulatory authorities changed the regulation because of that. Then value-based healthcare. Now healthcare systems are moving towards outcome-based reimbursement models. And of course, as Dr. Lalu said, that is for quality improvement and maintaining the continuous quality improvement in clinical practice. And most importantly, engaging the patients and involving them in the clinical care. So introducing PROMs in cataract surgery. So the outcome measures defined, basically there is a standardized questionnaire. We modified this questionnaire to our Indian patients and did the first study. So this actually helps to bridge between clinical success and patient satisfaction, and it is evidence-based. So PROMs tell us about the patient's life after surgery, whereas clinical parameters tell us about the surgical process. So basically, this is personalized surgical care, not one size fits all solution. And beyond visual acuity, what patient really wants. So to understand them, these questionnaires really help. So modern cataract patients demand more, not only the 6/6 vision, but also spectacle independence, functional vision for daily activities, quality of life improvement, and lifestyle specific visual needs. So apart from the traditional retired lifestyle that we tend to accept for our elderly patients. So our study was a first study to adopt this, and we studied 197 patients, and the overall satisfaction rate after cataract surgery was 87%. And with use of multifocal and trifocal lenses, it raised to 96%. And with monofocal, because of the affordability issues and maybe some wrong patient discussion, when we put monofocal lens, the satisfaction rate came down. So it offered key insights. So the clinical success is not equivalent to functional satisfaction. We have to go one step ahead and ask them about their quality of life and requirement. So this was the study published in Tamil Nadu Journal of Ophthalmology in 24. And basically, we adopted this Swedish national study and the CatQuest questionnaire to our Indian patient needs. And so this CatQuest tool is being used in 11 countries. And these questions cover daily activities. And these are the questions that is explained to patients and their inputs obtained. So the response scale pre or surgery and post surgery was obtained. So basically, from surgical success to life transformation, we could see that patients are really happy that many of their complaints have been sorted out post surgery, and some of them express that the reading part should have been better or without need for reading classes. So basically, yes, without difficulty was our expectation from these patients. So how do we implement? So baseline is pre-treatment functional status. What are the difficulty level? And follow the patient at the 3 visits, first month, 3 months, and 6 months. So many of the patients come from faraway places. They drop out for the 6 and 12-month follow-up. Basically, we use the Google form to get the data and also integrated with our EMR, and some of the questions were administered through phone calls. So this is the basic implementation. Diagnosed with cataract in the clinic, they undergo cataract surgery, and within 3 months, we try to get the pre as well as post-operative and intraoperative clinical form full, and then analyze this. And in the post-operative period, we were able to interpret their difficulties. So if they had any visual difficulty, 20% was reduced, and the scoring was done with the help of an app. And so we were able to analyze the post-operative CAT along with this tool. So clinical decision making with PROMs, high near work, we try to counsel for multifocal or EDOF lenses. And driving concern, we tend to optimize the good monofocal lens to reduce glare. And if they are more digital device usage, enhanced depth of focus lenses. And basically, we do their lifestyle assessment and customized surgical approach to provide a personalized cataract surgery. It also helped in understanding the various intraocular lenses, while traditional approach we base on age assumptions and occasional questions on lifestyle as well as affordability. In the PROM approach, it was basically about the functional need assessment and personalized recommendation based on discussion with the patient-centered decisions. And this helped us to understand the patient better and provide appropriate counseling. So how to implement in your practice? You can use the CAT quest and modify according to the region based on the type of patients you see, and use a Google form or tablet-based administration. And preoperative counseling by the doctor and the staff or optometrist is essential. So we train our staff with a 2-week protocol for education and also about the IOL selection decision, because the initial counseling is done by the counselors and the final decision is taken by the surgeon along with the patients. And we also monitor this over a period of time, and the counselor used to flag for significant score changes. Suppose the vision is not improved post-operatively, either due to retinal problem or the lens-related problem, or the score is reduced because of patient expectations. So that actually gives a flagging. So these were the common challenges while implementing this PROM in our hospital. Low completion rate because we had patients coming from faraway distance. They don't come for just a checkup after 6 months or 1 year. And some patients felt that they can't use the Google form. They wanted a paper backup. And it does takes a lot of time in the initial phase. And staff resistance because it takes a lot of time to fill the questionnaire 3 or 4 times with the same patients. And of course, data interpretation, we had to hire an expert in understanding the using the tools as well as the study results. So benefit to the patient, we had to spend a lot of time that actually improved patient satisfaction and improved the communication. And so after with the data in place, we had validation of patient experiences, and it was a attempt to provide personalized care. And of course, patient thought they were involved in the not only the patient but also the attenders, that they are involved in the care process. And for our clinic, it improved a lot. The counselors and the optometrists spoke to the patient a lot of time and asking their personal questions. So the comfort factor with the staff improved, and the structured patient assessment also helped in other ways. So now they use the same tool not only for cataract, but also other disease like dry eye, glaucoma, and retinal disease. So while others are still counting letters on the charts, so we'll be counting smiles on the faces. So what is the return on investment? There were some initial cost for the tablets we used and the support people, the technology people. But that cost was very minimal compared to the revenue increase. The premium IOL improved and patient referrals improved. Most importantly, the satisfaction scores also improved. And so that became, so the payback period was hardly 3 to 6 months. And that was a wonderful return on investment on the time and the money we spent. That also helped us in our quality journey beyond accreditation, because this outcome reporting as well as this helped us to teach few other hospital in our region about the outcome measures, and also getting good Google review and patient satisfaction index. And basically, of course, the research opportunity, this was our first attempt, and now we are doing this for dry eye, for glaucoma, and diabetic retinopathy patients. So that keeps our optometrists and junior doctors engaged. So future, of course, we can use a lot of AI integration tools are now coming up, and we can also use the real-time smartphone-based monitoring. Now we are taking this questionnaire with WhatsApp also. So basically, what I predict, or what with all the quality professionals discussion, PROM will be the standard of care in the next few years to come. So explaining why you don't use them will be like explaining why you don't do OCT in retina care. So technology integration will really help in understanding patient requirement. So key recommendation is so you can start simple with the OSDI or cataract, which is very common in our day-to-day practice. Can train our staff on getting the data and gradually build in integrating this PROM in your day-to-day practice. So key takeaways, so PROMs bridge the gap between clinical metrics and patient experience, and implementation will enhance quality, efficiency, and patient satisfaction. The question is not whether to implement PROMs, but how quickly we can integrate them to improve patient care and patient outcomes. So let us measure the outcomes that matter to patients. And so these are the key references that will help you to understand the subject better. And this is a wonderful tool from ICHOM website that can be downloaded. And if there are any questions, you can contact me and we'll be happy to help you. Thank you so much for the invite and the opportunity.
Thank you so much, Dr. Nirmal Frederick. I think whatever the doubts may be on patient-reported outcome measures have almost all, or whatever the questions were, at least in my mind, you had the answers to all of them in your slides. And also, it looks very abstract, but you proved it correctly by the study that you've done, that it is very objective. There is no subjectivity which is involved in it. And even if there is subjectivity that is being measured, it is very important to measure it. So thank you so much. And we will have a panel discussion after our last talk. And this is going to be given by none other than Dr. Samina Zamindar, who is the founder and the medical director of the Zamindar Microsurgical Eye Center at Bangalore. I think she's also synonymous and has worked a lot in the field of quality implementation in healthcare organization in general, and also has been responsible for many of the training programs that she does on quality care in ophthalmology. So over to you, your talk, Dr. Samina. She is going to be talking to us on the subject of PREM, that is patient-reported experience measures. So to my mind, both of them, I thought PROM and PREM were perhaps similar, but I'm sure we would know how PREM is different from PROM.
Is my screen visible?
Ma'am, if you can just stop share and then reshare. And
Not yet, Samina.
Okay.
Reshare.
Yeah.
So when this mail was sent out, I think this mail has had the highest number of opening rates and click rates, because I'm sure, like me, every other person wanted to know what PROM and PREM is.
Yeah.
It's visible now?
it's visible. It's visible.
Yeah,
Okay.
I received a lot of message. What exactly is this and what you're going to talk?
Okay. So, very good evening to everybody. Thank you for all the participants who have joined live, and I'm sure this webinar will be available in a recorded form also. Namrata ma'am, I should congratulate that you sort of encourage such a unique topic for the webinar today. And I'm really honored and privileged that I'm speaking alongside Dr. Nirmal and Dr. Lalu. We have to understand one thing, that we have close to 18,000 standalone eye care practices. And when we speak about patient safety and quality, it's just not theory. Every ophthalmologist who sets out to work every single day wants the best for their patient, isn't it? The patient safety, the best quality, patient satisfaction. This ophthalmologist wants to grow and do well, but they are all afraid of a lot of things which even now around accreditation. So let's make this webinar more about how do you actually improve your patient satisfaction? How do you improve patient safety and improve the growth of your own practice and do well? Because there is a lot of work. There is a lot of work, and I'm just coming to that now. These are the learning goals for this particular talk. How PREM helps identify patient-reported gaps, how hospitals can involve patients to reduce errors, and how do you boost safety and satisfaction. But before I go to my goals, I sort of just want to bring up Florence Nightingale over here. That the very first requirement in a hospital is that it should do the sick no harm. Of course, and each one of us, we are setting out to do this every single day. It's just that we might not have the tools to do it. Our intention is all very good, all pure gold. But do we have the tools? Or when did we last take a class on how to do it better? A process driven organization can make the difference, can really help your patient be safe and improve your practice also. So let's talk in general about what people would normally do to do this. So why did we select cataract surgery? When the PREM proposal came from CAHO, we said, of course, cataract surgery. And why? Because globally, these are the IAPB data that there's a huge unmet need for essential eye care services. Look at this. Globally, 2.2 billion people live with vision impairment. 1 billion people vision impairment could have been prevented or has yet to be addressed. And cataract accounts for 65.2 million people who are visually impaired. Why am I throwing this data? The reason is that we all know that there is a lot of cataract work to be done, right? So what is the effective coverage of cataract surgery? 17.2% with a 612 threshold for the need of intervention and good quality outcome, and 24.8% for 618 threshold for need of intervention and good quality outcome. What does that mean? When you look at 17.2%, close to 83% people need cataract surgery. 24.8%, 75% people need cataract surgery with good quality outcome, right? So where are we lagging behind? Now, do you think that our communities, our people get a little sort of afraid of what's happening with the cataract surgery? Are there a lot of never events which are happening? Do we really believe that there are so many never events? Not just a never event like this, but never events like, a wrong eye, wrong implant, incorrect biometry, so on and so forth. So what are we doing for this? Where can we start? Where can we really start to improve? Go back to your practice and say, am I doing all what I need to do to keep my patient safe? So there is this quote attributed to Dr. Lucien Leap from the Harvard School of Public Health. He said that if you want to run a process-driven organization, don't blame your people and don't blame it on incompetent people, because incompetent people are at most 1% of the problem. The other 99% people are good people trying to do a good job who makes very simple mistakes, and it's the processes that set them up to make these mistakes. How about if we look at innovative processes? We could put some good thought process in making our systems, our SOPs, our processes in such a way that our people make less mistakes. And what if we make it easy to do the right thing and difficult to do the wrong thing? Isn't it a very wonderful concept? Make it easy to do the right thing, make it difficult to do the wrong thing. So on a day when your staff is really tired, has had a bad start at the day, they still will do the right thing because it's easy to do the right thing, and will still not do the wrong thing because it is actually difficult to do the wrong thing. So we always talk about the Swiss cheese model and say we need barriers before an error occurs. And Dr. Lalu beautifully spoke about air crashes. And of course, something which happened in Ahmedabad is very fresh in our memory. But every airline industry uses a Six Sigma, education, training, policies, technology, communication, checklist, and adverse event reporting culture. All these are barriers. Do we have enough barriers in our organization so that an error doesn't happen? And remember that after having all these barriers, there can be a day when all the holes of the Swiss cheese will align. And then, are you ready to face that error? Dr. Atul Gawande brought out the surgical safety checklist. As a part of an accreditation requirement, you should have a surgical safety checklist amongst your surgery document. But is this a checklist which is a role play which has to be played out in your operation theater with every single patient? A sign in, a timeout, and a sign out. It should not just be a tick list. And this is something which is very important, that with every single patient, are we doing this or not? A role play in your operation theater. Going forward from checklist, we have evolved into what is a do not miss list. Instead of having a long checklist which eventually becomes a tick list, we have come out with do not miss list, so that you're focusing only on those things which are critically important to safeguard the patient's safety and no harm. Make it short, sweet, make it easy to do for your staff. So create do not miss list in your practice at every station, every workstation in your organization. And documentation of critical information, critical communication. Use steroid drops for the duration mentioned only. This is a stamp which goes with every patient who is being dispensed steroid. Do not stop until advised to stop. This stamp goes with every glaucoma prescription. There's an adverse drug reaction alert card stuck to every file of a patient who has an allergy. So incidence reporting culture is another barrier which can help you. Encourage your staff to report any adverse events, right? The Convert Corrective and Preventive Action Guide from CAHO is a wonderful book, and based on that, Seva Foundation has come out with a beautiful corrective and preventive action guide for eye care organization, which Namrata Madam has shared with everybody and will reshare if required. So this is a small 3-minute video which tells you that an SOP, a checklist, a process map can make a difference. And if you do not have that already in your organization, please go to your organization tomorrow and think about it.
Patient safety is utmost importance to us. A part of patient safety involves safe surgery, which involves 3 components: sign in, time out, and sign out.
He is Mr. Navanita Krishnan, left eye, phaco-topical temporal incision, 23.5 diopter, toric T4. 44.68, 99, 45.92, 9 degree. Alignment is 6. Time out. Left eye, phaco, topical temporal incision, 23.5 diopter, toric. Sir, ஆப்ரேஷன் நல்லா ஆயிடுச்சுங்க. சரிங்களா? நீங்க நல்லா இருக்கீங்களா?
After the surgery is done, we make the patient sit and announce sign out, ensuring that the patient is stable and fit to leave the operation theatre, checking the vitals of the patient. in addition to what you have seen right now, we also, on the day of the surgery, ensure that all our equipments are working properly. We ensure the readiness for any ophthalmic complication and medical emergencies. And last but not the least, we ensure that all our instruments are sterile by checking the indicator strips of the autoclave machine.
No surgeon, however careful, can prevent medical emergencies during surgery. Monitored anesthesia care and presence of an anesthetist becomes vital. So Kaho's white paper is available freely, and Lalu ma'am is going to share that on the chat in the chat box now. Please go through the cataract surgery questionnaire of PREM. So patient reported experience measures. These 14 questions which are written over there, it might sound very simple. Oh, there are some 14 questions and now we can ask the patients. But you have to realize the value of this PREM study and how beautifully these questions capture the most critical areas of care in an eye hospital. So why PREM in cataract surgery? The PREM bridges clinical quality with patient experience. One simple thing like, I was scared during anesthesia. I wonder how long the discharge will take. Did somebody in your team talk to the patient about anesthesia? Was the patient reassured? Was the patient told about the discharge time? Was a discharge summary given properly written? These are simple, small things, and we take it for granted. You would have made systems and you would have said, of course, it's done in our hospital. Is it done with every single patient? How do you find that out? Who better than your own patient to answer those questions? So, this is how the study was designed. Phase 1, the tool development, multidisciplinary expert panel of 10 members, 31 experts validated the initial 15-item draft. Phase 2 was a pilot study conducted in 10 hospitals with 240 patients, an average age of 63.2 years, with a good internal consistency. Phase 3 was a field study conducted in 15 hospitals, total participants 582 with an average age of 61.8 years. So the hospitals, this is a list of the hospitals that participated in the PREM study from across India, high volume, mid volume, small volume hospitals, a mix of all different kind of hospitals, so that we get a feel of how a patient goes through all kinds of hospital and how the tool was designed. Experts created a checklist based on the cataract surgery protocols. Patient feedback helped improve clarity and relevance. SOPs, draft questions, feedback, and the final tool. And how each question was validated. Each question was reviewed by members of the hospital's multidisciplinary team in the first review phase only. Find out whether the question was did it give a clear understanding to the patient what was being asked? Was it really important enough, critical for the patient safety? And was it relevant to that particular surgery? There were totally 50 questions which came out. Out of them, only 14 were selected after the final evaluation. And these were the areas which were always kept in mind. The most critical areas: patient identification, infection prevention, patient communication, clinical care, privacy, and patient rights. So this is, of course, the PREM checklist, which is going to be easily available to each one of you, the 14 questions. And how do we do it at our hospital? Is it difficult to do it? No. We see our patients on day 1, day 7, and day 30. And when the patient comes on day 7, this QR code is put in the optometry room. While they check the vision, either the patient or the patient's relative will just scan the QR code, the questions appear, the optometrist or any team member will help the patient to understand this, and the answers are given. Now, fortunately, Kaho has come out with so many different vernacular languages. So you don't need any translation for this. And the same questionnaire is available in all languages, most of the Indian languages. So that's the beauty of this particular PREM study. Now you can use it in the language in whatever region you are staying. And this was what the patient reported in our particular study. There was a yes response to all these questions. So that's definitely, this shows that in the organization in which this PREM study was done, all these safety related critical processes were taken care of. Infection prevention, sanitizer, medical history, whether the patient was assisted during transfer, patient communication, in whether the patient was informed about the eye condition, the lens option explained, the post-operative care explained, prescription for eye drop received, advice on what to do in an emergency, consent and understanding, financial awareness, patient identification, patient rights and privacy. We all agree that the fact that there was this paradigm shift in how patients perceive doctors, from the doctors are God to they doubt every single thing which is done in a hospital, in any organization. When this is the scenario in Indian healthcare now, it is this particular tool, and like Dr. Lalu said, that we make patient drive the care, not just making patient the partner, but allowing the patient to drive the care, their own care, make them responsible for their own safety. And these are the key takeaways, that in our systems, in our processes, humans are fallible and the world around us strongly influence our performance. So we do not redesign, we redesign the system within humans' work. And PREM is a beautiful tool which allows you to redesign your process, learn from your own patient, and get an unbiased view of how patient safety is taken care of in your organization. I wanted to keep this talk extremely simple and short so that we can have questions and discuss further. Thank you once again for giving me this chance to talk to each one of you.
Thank you so much, Samina. I think between all the three talks, we've actually spelt it all. We would have a panel discussion now, and before that, I would request Mr. Navneet Kumar Pathak from Microvision to run a very short video.
Thank you, madam. I'll just share the video. Yeah.
So thank you, Navneet, and that was a promo of the Lifitegrast which Microvision is marketing, one of the best drugs, I think, as far as dry eye immunosuppression is concerned. So we move on to the panel discussion, and I have questions for the panelists. Dr. Nirmal, I would just want to ask you that I'm sure there must be barriers and there must be the fact in your mind whether, this is going to, how much, because as practitioners, we always think of what it is going to give you in terms of finances. So what were the barriers that you had in the study? I'm sure from the staff, it must be an additional work and they must be complaining that, why should we do it or is it really required? And second thing is also in India, we are not, used to asking patients how they feel. We just take the vision, feel happy that, okay, done, the patient is 6/6 or whatever, and it's over. So I
Yes.
think you opened a new chapter. So what would you want to comment on this?
Yeah, thank you, Dr. Namrata. That was a nice question because that's what we actually faced because it was the initial phase and we had trouble training our staff. So there were challenge on resistance to change because it takes a lot of time with the patient. And another one was language barrier because initially we had this questionnaire in English, and some of our patient couldn't read or understand the context. So then we translated to the local language and asked our staff to use the local language to get the data. And of course, there was challenge with the time because it took about 20 to 30 minutes in the initial stage till we train our staff properly. And the usage of the gadgets, the tablet and smartphone, even though they are familiar with that, some of the patients were not familiar. So these were the initial challenges. But over a period of time, the young optometrists, we relegated this job. So they were quite smartphone savvy and they adopted to this. The barrier with the patient was we were asking some uncomfortable questions, particularly about the experience in the hospital as well as their actual requirement. Because some of them would say one thing with the optometrists and with the doctors, they may not like to say. So these were the initial challenges. But overall, it was a good learning experience for our staff as well as doctors, because now the junior doctors also understand they have to counsel about all their requirements and ensure they validate the history taken by the optoms and the counselors. So that is a good thing and benefit out of this study for us.
You also did say that you are doing this for not only cataract, but dry eye, maybe glaucoma, maybe diabetic retinopathy as well.
Yes, so we are doing this as part of our clinical audit for dry eye and glaucoma, and now recently started for diabetic retinopathy post injections also.
Okay. So can you put this into your EMR as well? Whatever this, whatever EMR you're using or whatever anybody is for that matter using, can this be part of EMR you think, or it will remain a separate thing?
Yes, so actually it is challenging to use two electronic tools, but our present EMR do not support this when we started this study. So we designed Google Forms and then used an Excel sheet and also with the help of scientific coordinators from the Indian Institute of Epidemiology, we had to validate some of the data, clean the data, and then only arrive at the diagnosis and the results and the discussion. But now we are planning to use a app. So we sought the help of an IT fellow who said he will get this done and integrate with the existing EMR. So we are not integrated so far, but the process is on.
And how far, and I think even Dr. Lalu Joseph can answer this, how far have our regulatory bodies incorporated it into their system, or they have not incorporated at all, NABH, QCI, and others? Or is it mandatory for them? I'm sure I don't know whether it is mandatory from their side, or does it help to fulfill their requirements additionally?
Absolutely. After the World Patient Safety Day and the theme of patient engagement, actually, it has become a mandatory requirement as per the NABH standards and JCI standards as well. So hospitals that are going in for accreditation, particularly full accreditation, will have to comply with the PREMs and PROMs. But lot of clarity on PREMs and PROMs have come in now with CAHO's intervention of actually validating these tools. Otherwise, tools were available with ICOM. They are still available, but they are for a price. You'll have to. There are only certain number of free tools available, which is the main reason as to why we went ahead and developed context-specific, India-specific tools so that our hospitals can replicate them and made them available free of cost. Another interesting thing is with regards to the ranking of hospitals, the global ranking of hospitals. They give weightage to hospitals conducting PROMs and PREMs. It's quite a lot of weightage that is given for hospitals. So that is also an incentive. So more than making it mandatory, I think all these accreditation bodies have made it like an excellence standard where you think beyond accreditation and you go into patient engagement and as a level of excellence, which is where it is now. But there is no mandatory requirement per se. Even accreditation is a voluntary exercise. But once you get in, yes, full accreditation, it is one of the mandatory requirements as part of accreditation.
So you've done it in so many specialties, not only ophthalmology, which has given you the, which is your best running specialty, if I may say so, in terms of PROMs?
Certainly, ophthalmology is one of them. Because considering the number of small hospitals and the tool that we have developed is also a very, very simple tool. PROMs is also under development now that has only 7 or 8 questions that is getting validated. So ophthalmology is one, anesthesia is another area. MRI safety has been well accepted and antenatal care. These are the 4 areas that have really taken off, I would say, considering the feedback I'm receiving from the country and the hospitals.
That's nice to know that, there are antenatal care, etc. So wherever the subjective perception is there in terms of, senses and measurable or subjective perception, quantification, I think there it really works well. What about Dr. Nirmal and Dr. Samina? I think, or all 3 of you can take a comment on that. What do you think is the medico-legal implication of that? Suppose the patient says, I'm very satisfied and goes and does a litigation case later on. So how does it save the hospital, or how does it counteract the patient, saying that, you said something else in PROM and PREM. So do you think, can we take it on a legal, can it hold on a legal ground as well?
Yeah, definitely, because it is also a risk mitigation method, because the history is taken and documented. This is a valid document that shows patient concerns, his symptoms, and the methodology the hospital or the care provider adopted to provide relief to the symptoms as well as give good experience. So this demonstrate and also this questionnaire demonstrate patient involvement in planning the care, whether it is surgical care or any other laser procedures. So that is important as long as documentation is concerned. And since the talk is documented or this discussion is documented, that actually helps with the consent documentation also, because the patient and the provider is involved in all this questionnaire. So now we know the patient's reasonable expectation. We always strive to provide the best outcome to the patient. As far as legal procedure, there's nothing illegal about it, or this will not go against the medical establishment, because we are documenting what the patient wants and trying to provide the solutions. In the process, the whole thing is documented. So that actually acts as a shield for the hospital.
If I may, yeah, come in. I think this is the most common question asked. Now you're taking the feedback from the patient. What if the patient says that the surgical side marking is not done? Can it be a legal implication on the hospital? Again, it's a perception, madam. whether the perception of that patient that he's answering, and most of these are anonymous, and we are collecting from 100 and 200 patients. That way, if we look at it, we cannot audit our practice at all, because anyway, while auditing, we are documenting whether it is a cardiac arrest that happened or otherwise. These are quality improvement exercises. So that is why we say, collect N numbers and not limit yourself to 1 or 2 patients. So certainly this is not going to be a tool that is going to be used against you, and not that we are going to be collecting from all patients also. It's a sample that we are taking to understand whether our systems are functioning better. So that's the way to take it. More than all these feedback, we have a lot of other problems actually to address too when it comes to medico-legal. So this is certainly a quality improvement exercise, and that's why we say in the beginning, it's your perception, and give your opinion on whether this happened or not. That's,
Yeah,
I
just
hope
to
I
add to
answered.
it, there is always, once we get this, maybe a negative response from the patient or their attender, so there is an opportunity for the hospital staff to recover their service. So it helps in service recovery. Some senior person can intervene and trying to make the patient understand. So it is actually an opportunity for us to, before they go to a lawyer or a legal solution, it's an opportunity for the healthcare providers to address the issues.
Samina, do you think it is like you talked about PREM, patient-reported experience measures? Do the patients actually respond correctly?
Yeah, so Namrata ma'am, that's true that it's not so easy to get the responses from the patient, and the patient sometimes just wants to keep us happy. They'll say yes, yes, yes for everything. So
Sometimes
here
they
the
want to upset you also, so they might say no, no for
yeah,
everything.
that's also there, both the ways, of course. Mostly it is they just want to be in your good books because they feel hospital hai to abhi bhi they'll say doctor hai, and with the respect. So doctors don't generally do that. It's one of the team members do it, ask the questionnaire. And I love the PREM tool because I feel the 14 questions which are there in the PREM tool, and I hope everybody who's attending this webinar opens those questions and sees that in the white paper, that they actually define all the patient-centric areas of an organization, right? Starting from communication, discharge, consent, some infection control. And so first if an organization has just started, they would want to put these things into place, these 14 things into place, that ye to hona chahiye. It's a part of the patient-centric organization. Then you sort of train your staff that now we are going to ask the patients only about this. So they are a little more alert that patients will be asked, so they are on their toes and that things are done. And then thirdly, you actually go ahead and implement and ask patients. So if you do this exercise, the PREM exercise in stepwise, step 1, 2, and 3, it definitely is going to help your organization. And I feel that whether the patient answers it correctly or not, your aim of improving the patient safety and quality of care in your organization, that goal is fulfilled.
And isn't your staff, scared that in this PROM and PREM, the patients might say things which are not very good about them, if they've not, treated them well or behaved well, etc. Maybe it's a safety guard for them also, so that they behave.
Yeah, absolutely. And if they are scared, so be it.
So we have Dr. Piyush Bansal, our member, scientific committee. Also, Piyush, would you want to ask any other question?
Very good evening, ma'am. Right now, I'm just being an attentive viewer and learning about the various aspects. I'll surely join in a bit with a question, ma'am.
So I think we would like to also tell everybody, and everybody I think knows about it, that Microvision was instrumental in getting all the consents of the ophthalmic surgeries in various languages all across the states for our All India Ophthalmological Society members. And we would again like to thank them for this, a task which was quite daunting, which was successfully done. And I would like to thank all the viewers and all the people who are watching this. This is not the conventional type of a webinar on clinical ophthalmology, but something which only these 3 experts can teach you about, because they've gone through it. Otherwise, like I said, we have the highest number of click rates because I know, like me, even people didn't know what is PROM and PREM. And I also found it very amusing. But I think we've had a great insight into what they are. They are going to be the future. And as far as the regulatory is concerned, they are going to be very helpful. So I'm thankful to all the three speakers, Dr. Nirmal Frederick, Dr. Samina, and Dr. Lalu Joseph, and who continue to actually inspire us and continue to contribute towards the quality as far as the ophthalmology practice or medical practice is concerned. So thank you so much. And I would also like to thank Microvision for coming up with this brilliant idea. Ophthalmology Pathshala is their brainchild, and Microvision Academy is also their brainchild. And we are going to continue this with almost every month webinar on one or the other topics which are unusual. So thank you again so much. And it's always lovely to meet you, Dr. Nirmal and Dr.
Thank you,
Samir,
Dr. Mehta.
Dr. Lalu, whom I've been introduced today. Thank you so much.
Thank you.
Thank you very much.
I'd like to thank our audiovisual partner in this, Mr. Sunil, who's been doing our Zoom webinars, not only from now, but from the COVID era. So for last 5 years, he's been with us. And thank you so much, Sunil, for doing it flawlessly each time.